everyone. This is going to be sort of an introductory video to the clinical presentation of various joint conditions. So in this video, I'm usually going to be going through arthritic conditions, but at times I will be talking about some crystal arthropathies such as gout and pseudo-gout. I'll also be talking about the classification of various arthritic conditions. So the common classifications that we use for arthritic conditions include, firstly, we can classify an arthritic condition as being arthritis with inflammation. And this is pretty self-explanatory. This is essentially a joint condition where we have inflammation of the joint as well. So this is a true arthritic condition because by its very nature, arthritis is a condition where a joint is affected, which is arth, and itis refers to inflammation. An example of a condition where we get arthritis with inflammation is septic arthritis. And septic arthritis is when we have a bug infiltrating into a joint, and that bug causes for inflammation and quite painful lack of function of that joint. We can also have what's called arthritis without inflammation, and this is pretty much a misnomer because arthritis without inflammation is pretty much just arthralgia, because the patient will still have pain but not necessarily any itis or any inflammation. An example of arthritis without inflammation, I just realized I wrote the same thing, without inflammation, is osteoarthritis. Now, osteoarthritis may look like it is an inflamed condition because we usually get some sort of an increase in size of the joint itself. However, this increase in size is not due to a buildup of any edematous fluid or any inflammation. It's rather due to the formation of joint mice, or what we call osteophytes. And these osteophytes are projections of bone that form around the joint due to the breakdown of bone occurring in that area, usually due to repetitive trauma. Another classification of arthritic conditions are hemorrhagic arthritis. Hemorrhagic arthritis. And these are less common, but examples include hemophilia, which is a bleeding disorder. And hemophilia can especially cause for hemorrhagic arthritic conditions because a person is unable to control or does not have the appropriate control mechanisms in their blood to prevent bleeding, and that subsequently means that the blood can infiltrate into the joint if, say, the joint undergoes a lot of trauma and cause for arthritis or inflammation of that joint due to the presence of blood which is normally not present within a joint. Finally, we can have what's called avascular necrosis. And avascular necrosis, as its name suggests, is a condition where we get a lack of proper blood flow to a particular tissue, and that causes the death or the necrosis of that tissue. And this is most commonly seen in what we call a scaphoid bone fracture. And the scaphoid bone is a bone that is present on the carpal bone region of the hand, and the reason why avascular necrosis is so common with the scaphoid bone is that the scaphoid bone does not actually appear quite clearly on an X-ray. So if we suspect a patient has a scaphoid bone fracture, we can't tell based on an X-ray. And unfortunately, since the scaphoid bone does not receive quite a large amount of blood circulation, or essentially does not get enough blood from blood vessels, if it is fractured and blood vessel supply is cut off, it undergoes necrosis. So the only way we can accurately see if a person has a scaphoid fracture is by palpating their anatomical snuff box, which is a small area on the just sort of on the medial side of the hand. Actually, I should say the lateral side of the hand, proximal to the carpal bone, so near where the wrist is, and it's an area where if we press into it, we can directly palpate the scaphoid bone, and we ask the patient if they experience any pain when you press here. If they say that they do, then, well, they are likely to have some sort of injury to the scaphoid bone. So these are 4 examples of classifications that we can use to classify arthritic conditions. 2 other conditions or 2 other classifications that I want to talk about today are whether an arthritic condition is seronegative or seropositive. Now, seronegative and seropositive conditions can be further classified into being either inflammatory or non-inflammatory. In this video, I'm going to be talking about simply seronegative and seropositive inflammatory conditions. So if we first talk about what seropositive and seronegative actually means, well, sero refers to the serum or the blood. So if a particular arthritic condition is seropositive, then we are able to perform particular tests that are able to show us that the arthritic condition is present simply based on a blood test. So these arthritic conditions that are seropositive will have certain effects on the blood, which will cause for blood markers to either be elevated or changed in some way that we can identify that this condition is present. Seronegative conditions, on the other hand, are the complete opposite. We aren't able to determine that a particular condition is present, and since there are no blood markers that allow us to show that that condition is present, the condition is marked as seronegative. So there's no blood indicator that is present. So examples of seropositive arthritic conditions include rheumatoid arthritis, and rheumatoid arthritis can be seen in the blood due to the marker ACPA or ACPA. SLE or systemic lupus erythematosus, and that can be sensed due to the ANA or anti-nuclear antibody marker. Vasculitis in general, so this is inflammation of blood vessels, and a condition called Sjogren's syndrome. Seronegative arthritic conditions, on the other hand, do not have any markers that show their presence, and they include conditions such as ankylosing spondylitis, which is when, usually in young males, there is the formation of what we call a bamboo spine, and what that means is that we get a very straight spine, and essentially the person is unable to bend over or bend backwards since their spine is so straight, and it's usually due to the fusion of the joint spaces between the bones or the vertebral bones. Reactive arthritis is also a condition that does not present in the blood. And psoriasis. So to quickly recap, arthritic conditions can be classified in 4 main categories. Firstly, arthritis with inflammation, arthritis without inflammation, hemorrhagic arthritis, or avascular necrosis. 2 other classifications include either seropositive or seronegative inflammatory conditions. Seropositive conditions include rheumatoid arthritis, SLE, vasculitis, or Sjogren's syndrome. And seronegative conditions include ankylosing spondylitis, reactive arthritis, and psoriasis. And it's important to remember that seronegative conditions present with no markers in the blood, and therefore blood tests cannot show the presence of these conditions. Now, when we think about the common clinical presentations of arthritic conditions and conditions that cause bone pain, there are certain pain patterns that we can see, and the patient may tell us these pain patterns. They may say that they are concerned about sharp pain, burning pain, pins and needles, or we may find this on a physical examination. So when we move a particular joint, movement of that joint may incite some pain, and that pain may be accompanied by a loss of function or other features. So on this slide, I'm going to talk about what the patient may say in regards to gout pain, bone metastasis pain, inflammatory pain, osteoarthritic pain, and finally neuralgic pain. Let's firstly start with gout. Now, gout is a condition that results in quite isolated and rapid onset attacks. So these attacks usually occur on one specific joint, and the stereotypical or the real most common joint that we see is the joint of the big toe on either left or right foot, the base of the big toe, and this is due to the deposition of those needle-like monosodium urate crystals which cause for pain in that joint. So gout onset pain is rapid onset pain. The patient may complain that then when they're just sitting, maybe sleeping in bed, they'll suddenly feel pain and they can't even rest even their sheets on their foot. That's how painful it is. Now, bone metastasis pain is interesting because usually it doesn't occur during the day. It occurs, on the other hand, during the night. So pain is present at night. So pain at night. And additionally, it's not just any normal sort of pain. It's sort of very deep, and it's kind of annoying pain. And the unfortunate thing about bone metastasis pain, kind of in lieu with how serious this condition is that the patient will say that they can't alleviate this pain. So no matter what position they move into, they can't alleviate the severity of the pain. And that's because the actual source of the pain is coming from within the bone, as opposed to an external structure that's causing for pain on the bone. Usually these bone metastatic tumors are present within the actual cavity of the bone, and whilst being present within that cavity, they expand and cause for a quite uncomfortable force on the bone, which can cause it to disintegrate from the inside. The next type of pain that I want to talk about is inflammatory pain, and this is the kind of pain that you will see with inflammatory arthritic conditions. And patients will always, or most of the time, complain of stiffness, usually in the morning. So especially with conditions such as rheumatoid arthritis, reactive arthritis, because the actual joint has been so immobile for a period of time, let's say if the person sleeps 8 hours a night, that particular joint is unable to be moved, because obviously when you're sleeping you don't move, and that means that there is a lack of functioning of that joint, which means that the bones and the joint cavity stays in one place for an extended period of time, and that is what causes the stiffness. If you imagine if you've been lying around all day, you usually feel a lot more lazy at the end of the day, and you don't really feel like doing stuff. That's the same concept here, and except it's not really something that is associated mentally, but rather it's actual stiffness. The patient isn't able to move their joint in the first place. Now, osteoarthritis pain is something that I have written separately here, because as you'll remember that osteoarthritis is actually not an inflammatory condition. Now, osteoarthritis is pain that is caused when there is, unlike inflammatory arthritis where we see pain first thing in the morning, osteoarthritis pain occurs, or stiffness I should say occurs, with activity. So this is the clear delineation that I want you to draw with inflammatory arthritic conditions and specifically osteoarthritis. Inflammatory arthritic conditions can cause pain regardless if the patient is active or not, but with osteoarthritis, since the patient is more likely to develop that pain with activity, because osteoarthritis is a condition that is associated with trauma and repeated trauma. That stiffness and pain is only going to be present in those scenarios. Now, the final type of pain that I want to talk about today is neuralgic pain. And neuralgic pain, as its name suggests, is pain associated with nerves. So a patient will describe pain as being deep because, and that makes sense because nerves are found, I should say, in deeper sections of the body. They are deep below the skin, so the pain will be present there as well. And in addition to deep pain, they will complain of paresthesia. And they won't specifically say paresthesia because this is not a word that people commonly know, but they will say pins and needles. And pins and needles can be quite painful if a patient has had chronic or prolonged compression of a nerve. So they will be quite upfront about this. If you move a joint, and they will likely complain of a large amount of pain if that movement causes pain. So on this slide, we've looked at gout, which causes rapid onset pain, bone metastases, pain at night, inflammatory pain, stiffness in the morning, osteoarthritis, stiffness with activity, and finally neuralgic pain, which causes deep pain and paresthesia. Now, I wanted to also talk about 3 different patterns of joint pain. So on the previous slide, we looked at how different types of pain manifest in different conditions. But in this slide, I want to talk about how pain can spread between different joints. And there are 3 different ways that which osteoarthritic or arthritic pain of any type can spread. Firstly, the pain can be migratory, and I'll get into their definitions a bit later. It can either be additive or it can be intermittent. Now, knowing what the definitions of these words mean is quite simple because their general definitions relate to what their definition is in reference to the body. So migratory pain, as its name suggests, is pain that may only last for a few days, but the pain migrates or moves from one joint to another. So it's quite acute pain, so let's just write it lasts for a few days and moves between the joints. And the important thing to consider about migratory pain is that once this pain is present in one joint, it goes away in that joint and will likely move to another joint. And that's what differentiates it from additive pain. Now, additive pain is when there is pain in more than one joint, and as the pain spreads between the joints, the pain adds up on itself. So the clear difference between migratory pain and additive pain is that additive pain is present on many joints, and the pain gets added on subsequent joints. And this pain is commonly seen, or this pattern of pain is commonly seen with autoimmune conditions. So conditions that cause joint pain such as rheumatoid arthritis, systemic lupus erythematosus, they will all cause an additive type of pain. Intermittent pain, on the other hand, is, as its name suggests, pain that is not always present at all times. It is kind of like episodic pain. It's only present at certain periods of time, and it comes and goes at intervals. So another word that you will see to describe episodes of a particular disease is episodic pain, or episodic patterns of a disease. So intermittent pain is episodic pain, and it comes and goes away at intervals. And this can kind of be likened to osteoarthritic pain, because osteoarthritic pain is only present with activity, and with rest we can alleviate that pain. So it's only present at certain episodes. But The same thing can be said for conditions where there is no clear trigger for the actual symptoms, such as systemic lupus erythematosus, when certain flare-ups can occur at certain periods of time, but those flare-ups are not necessarily there all the time. So on this slide, we've looked at 3 different patterns of pain: migratory, which is when the pain moves around; additive pain, pain moves around, but the existing joints still remain with the pain that was initially there; and intermittent pain, which is episodic. Alright, so this is just going to be a short slide, and it's just going to talk about a few different other classifications that we use for arthritis. And these classifications don't relate to the type of pain or the method by which the pain moves around, i.e. the pattern, but rather how many joints have been affected. So there are 3 key terms that you have to keep in mind when we are defining how many joints have been affected by arthritis. And the first term is monoarthritis, followed by oligoarthritis, and finally polyarthritis. And as you can see, as we are writing these words, the number of joints affected is going to be increasing. So let's define what these words mean. Monoarthritis is pretty self-explanatory. This is when arthritis affects one joint only, so one joint is affected. Oligoarthritis, on the other hand, is arthritis that affects more than one, or let's just write more than one, but less than 5 joints. So this is where the definitions of these conditions can become a little tedious and a little bit difficult to understand or memorize, I should say, since there are very specific classifications for both of these arthritic conditions. You pretty much need to have only between 1 and 5 joints being affected for oligoarthritis to occur. And as you can guess, for polyarthritis, this is an arthritis that affects more than 5 joints. Now, a little clinical side note that I want to make on this slide is that you may not always see oligoarthritis being used in clinical scenarios just because its definition is so slim in that it only relates to 1 to 5 joints, that people may commonly use polyarthritis just to describe arthritis that affects more than 1 joint, but that is a little bit rare. But it is something that I wanted to flag because sometimes people do not use the nitty-gritty details to classify arthritis, but this is quite widely accepted classification. Alright, so now I want to quickly talk about, before I move on to the next slide, what actually causes these conditions, or the conditions that relate to monoarthritis and polyarthritis specifically. So monoarthritis can be caused by many different disorders. Firstly, let's say if we write it up here, monoarthritis, and I'll just list them off here. Monoarthritis can be caused by infections, so think about conditions such as septic arthritis, inflammatory arthritic conditions, so inflammatory arthritis. This includes conditions such as juvenile idiopathic arthritis, certain bone and cartilage disorders. So say if we have a autoimmune condition that specifically affects bone, or for example injuries such as trauma to a bone or cartilage, that will cause trauma monoarthritis. And lastly, yes, as I mentioned earlier, trauma is another aspect of monoarthritis, or a cause. And trauma can cause what's called hemarthrosis, which is when there is the infiltration of blood into the joint space or the joint capsule, and that causes unnecessary pressure on the joint, which causes pain. Now, on the other hand, when we look at polyarthritis, some of the causes of polyarthritis include rheumatoid arthritis, and these includes conditions that normally present as polyarthritis, so rheumatoid arthritis, seronegative spondyloarthropathies, and this is a long word, and I will write it in full just so you know what the spelling is. So seronegative spondyloarthropathies. So seronegative, as we explained or as we explored earlier, are conditions that do not present with a bone indication. So when you take a blood indication. So when you take a blood sample from the patient, there are no markers present in the blood sample that may indicate that this person has that condition, because that condition itself does not present with any blood markers. Systemic lupus erythematosus, which I'll abbreviate as SLE, gout, ankylosing spondylitis, which is a condition that we have talked about briefly in this video, sorry, I just spelled it wrong, spondylitis, osteoarthritis as well, because as you know, osteoarthritis can very well affect one joint, but if a person is getting repetitive trauma on more than one joint, such as maybe if they are a marathon runner, they can get osteoarthritis in both their knees. Psoriasis as well, because psoriasis is an autoimmune condition. Interestingly, a condition called irritable bowel syndrome can also cause polyarthritis. And the thing with many autoimmune conditions is that they can commonly present with joint pain. And that's something that we've seen with systemic lupus erythematosus, in that 90% of people with that condition can present with joint pain. So it's important to remember that these autoimmune conditions can cause polyarthritic pain. Now, the last classification, or the last cause that I want to talk about for polyarthritis, is reactive arthritis. And that sort of leads me on to a good segue into the infectious causes of arthritis in general. And these infectious causes usually cause monoarthritis when they allow for infiltration of the joint space, so they are confined to that one joint. However, they can also cause oligoarthritis or polyarthritis, depending on how much of the body has been exposed. If the patient is suffering from sepsis or some sort of systemic infection, then these particular causative agents, which are infective agents, can cause multiple joint attacks. So common infectious causes of arthritis in general, and I'll just note them down in this separate section here, include salmonella. So this is obviously due to a gastrointestinal origin, could be through the consumption of contaminated food. Chlamydia trachomatis, and obviously this is a genitourinary infection, and like many other infective arthritic conditions, or I should say, sorry, it can cause septic arthritis or reactive arthritis, because if this particular bug is present within the genitourinary tract and the infection is cleared, but the immune system goes into overdrive and attacks the joints, that's what reactive arthritis is. So these are the two common infective causes of arthritis. So on this slide, we've gone through monoarthritis, oligoarthritis, and polyarthritis. We also looked at the causes of monoarthritis and polyarthritis, and we also looked at the infectious causes, the common infectious causes of arthritic conditions, which include salmonella and chlamydia trachomatis. Alright, so before we finish this video, I quickly want to make a quick side note on the physical examination findings that are not related to joints that you may see in a musculoskeletal examination. So whenever a patient presents with joint pain, you should always perform a musculoskeletal examination. So that means testing their joints, even the movement of other muscles that are associated with that joint. And you should be also looking for certain features on the patient's body that may indicate a joint condition being present. So I'm going to provide you with 5 examples of places you should be looking at in identifying a joint condition. And the first one is the most obvious. When you're assessing a patient with a joint condition, you should always look at the joint that has been affected, so the actual joint that's been injured, and the contralateral joint. So this is more so for a comparison, but say for example, if a patient presents with osteoarthritic like pain in their left knee, then it is always important that we look at their right knee as well. And that's not just for comparison, but we get a gauge on, say for example, the cause of the patient's pain. If they were a runner, it's likely that both of their knees will be affected, but since only one knee is affected, it's likely that they are going to be having a lot of repeated trauma on only one side of the body. So it can allow us to insight a lot of different things about the patient's cause of illness, as well as the condition itself. Secondly, we look at their skin and nails, and that's very important because especially I want to highlight nails, because conditions such as psoriatic arthritis can cause pitting of the nails, and as we all know, psoriasis is associated with those skin rashes. So if you suspect a patient has psoriatic arthritis, then you can ask them that you want to have a look at their skin and nails, especially where there are pieces of skin or parts of skin that are associated with joints, so skin that is highly mobile, that's more likely to present with psoriasis. And the reason why we may not see any skin or nail manifestations is that sometimes psoriatic arthritis can present with just joint pain, and this joint pain can occur before the actual onset of psoriasis, which is a skin condition, can occur. Thirdly, and this may look a little bit, out of the way or in the left field, we also look at the patient's mouth. And the reason why we look in a patient's mouth is not necessarily to identify monoarthritic conditions or conditions that specifically affect one joint, but the mouth can be a good indicator of systemic conditions, because a lot of autoimmune conditions and other systemic infections maybe can cause for mouth manifestations. For example, dry mouth is a very common manifestation of arthritic conditions that have autoimmune origins. So that's something to keep in mind as well. We also look at the patient's eyes, and once again we may look for conjunctivitis, maybe if we have a suspicion that the patient is suffering from reactive arthritis from that condition. We may also look at their eyes, dry eyes along with a dry mouth. So here you can see a trend of a mucosa being dry because the eyes and the mouth are both part of the mucosa. So obviously we're going to look at those structures just to see if there are any systemic manifestations of any joint conditions. And finally, we obviously, with the patient's consent, and only if the situation is right, and what I mean by that is when you've been with the patient for a long period of time, you usually won't do this on the first consultation that you have with the patient. You may have a look at their genitals, especially if you suspect that a patient is having joint pain, and that joint pain may be due to reactive arthritis, and you are quite backed up in doing a genital examination if the patient is a male as well, because the incidence of reactive arthritis due to sexually transmitted infections in males, it's much higher compared to females. So doing those examinations may be warranted in that situation. So in this slide, we've looked at the 5 main areas of the body that you may look at for joint conditions, and they are good indicators of systemic conditions as well. I hope this video has made sense. It's been another long video. I feel like I'm saying that in every video from now on, but thank you very much for sticking around. I hope it all made sense, and thanks for watching. I'll see you in the next one.